Welcome to the fourth installment of our Sex Talk podcast. I'm Lisa DiGiorgio-Haig, nurse practitioner here at Student Health Services. I'm here today with Larry Lariosa. He's one of our mental health psychotherapists that works alongside me. Due to the number of questions we've received, we're unable to answer them all on the podcast today. We've tried to pick the most global questions that would apply to the most students. So if your question is not covered, please don't be insulted. Just make an appointment with one of the providers here, and we'll be happy to help you answer it in our office one-on-one.
Hi, this is Larry from UCSF Student Health, and topics to be discussed on this episode of Sex Talk include polycystic ovarian syndrome, anal sex, and oral sex. Our first question is, my younger sister, who's 27, was diagnosed with PCOS recently after she went off of BCPs and she didn't get her period for 8 months. I am 29 and went on BCPs when I was 22. I didn't have super regular periods from 13 to 22, but my doctors were never worried. My husband and I are planning to try to start to get pregnant this coming summer/fall. Should I go off of BCPs and have the hormonal tests for PCOS now, or wait until I'm ready to go off of them anyway? I haven't had any weight changes in the last 10 years, eat very healthy, exercise, and I have a little more hair, but have always been that way. Thanks. And Lisa, you might want to tease out all the acronyms here.
Yeah. Okay, this is Lisa, and first let me say PCOS is polycystic ovarian syndrome, and BCPs are birth control pills. So I'm going to try to talk a little bit about PCOS in a more global way. A lot of people are hearing more about this. I tend to personally think it's a little bit overdiagnosed. The criteria are not clear, and it's changing. So if you've heard something that's a little bit different than what I'm telling you, different providers are using these diagnoses in a little bit different way. So I'm going to tell you how I use them and what I know about it. So there's a little bit different diagnostic criteria for PCOS in adolescents and adults. I'm going to talk about the adult diagnosis. So PCOS is a syndrome. It's not a disease, and it can have multiple causes. There are different groups that have come up with consensus about PCOS. The NIH, or National Institute of Health consensus, says the syndrome is comprised of menstrual irregularity due to anovulation or not ovulating, hyperandrogenism, which clinically presents as sort of acne, and hirsutism, which is excessive hair growth, and that's why the person who wrote the question talked about how hairy she was, or malpattern balding, or biochemical concentrations of high serum androgens, and that's a blood test that you do where you look at somebody's androgenic hormones and see how high they are. You have to exclude other causes of menstrual irregularities and hyperandrogenism. There's another group of criteria put out by the Rotterdam Consensus that adds the visualization of polycystic ovaries on ultrasound. So you'd actually do an ultrasound of the ovaries to see if they have multiple cysts on them. So let's talk about frequency. It looks like about 6 to 8% of the general female population may have criteria meeting that would add up to the syndrome. And it's interesting to note because people who have this have an increased risk of obesity, insulin resistance, type 1, type 2, or gestational diabetes. They also have a history of premature ovarian failure, which basically means super early menopause. And it is true that this patient asked about her sister having it. If you do have a first-degree relative, your risk is increased. But I really like to remind people that they're their own person. So because her sister has this, yes, her incidence of it might be slightly increased, but you're not your sister, you're your own person. It really requires you meeting the diagnostic criteria and you having evaluation if you're concerned about it. And it also doesn't mean that she'll have trouble getting pregnant. and that everybody with PCOS does have trouble getting pregnant. It can increase your risk of infertility for certain reasons, but I've certainly had patients that meet the criteria for PCOS who get pregnant very easily. So whether or not she should go off her oral contraceptives early, remember, if you're on oral contraceptives and you want to get pregnant, it generally takes about 3 months longer to get pregnant after you're on oral contraceptives. But big warning here, that does not mean you should go off your oral contraceptives and have unprotected sex if it would be a disaster for you to get pregnant tomorrow, because I've certainly seen a number of people get pregnant very easily after discontinuing oral contraceptives. So these are averages. On the average, it takes people 3 months longer to get pregnant after using oral contraceptives. What I would do is I'd go off oral contraceptives and use a backup method like condoms for 3 months while your cycle sort of regulates itself again. And you can see if your cycles are regular or if you do need an evaluation. Now, infertility diagnoses are not made until somebody's been actively trying to get pregnant for 6 months to a year. So at her age, I wouldn't jump the gun on that. I think 29 still gives you plenty of time to try to get pregnant.
The next question is, are there any long-term risks associated with anal sex, particularly in regards to prostate enlargement or physical trauma to the rectum?
There's differing information about this in the community, and I consulted a couple different sources. It really depends on how active you are and who you're having sex with. So the risk factors with anal sex include lifetime number of sex partners, whether or not those partners have genital warts, cigarette smoking, interestingly enough, whether you participate in receptive anal intercourse, or whether any of your partners are infected with HIV, or whether you're infected with HIV. Now, there's a great website that I love that I use a lot called Go Ask Alice. It's put out by Columbia University Health Services. So what they say is that anal sex enthusiasts can relax, which is a good thing to do during anal sex anyway, and it doesn't loosen the anus or cause an inability to control bowel movements. However, they agree there can be risks associated with anal sex other than STDs, so it's important to take steps to minimize these risks. They list friction as a big enemy of anal sex, and I would agree with that. So steps to safer anal sex include being very gentle and moving slowly, using plenty of lubricants, not just saliva, using a condom, a lubricated condom, avoiding spermicide because that can really irritate the rectum and actually increase your risk of transmitting HIV, never moving from anal to vaginal sex without first changing condoms, and stopping if there's pain during penetration, which I think is a good rule for any kind of intercourse. It can make you more susceptible to bacterial infection around the anus and rectum. And that's basically because the lining of the rectum is not as heavy as the lining of the vagina, so it's more susceptible to tears. So you have to be careful and use your lubricants to prevent that. You should get seen if there is a tear or a fissure, because these can become chronic problems and have bigger issues down the way. Avoid it if you have existing hemorrhoids, because it can definitely make your hemorrhoid problem worse.
The next question is, if I receive oral sex, not give, should I get tested for STDs?
I'm happy someone out there is getting oral sex. I think that's a great thing, and I hope you're happy with it. And I would say oral sex is safer sex, but it's not safe sex. So the thing it brings to mind primarily STD-wise is herpes. If your partner has oral herpes, and by that I mean cold sores that occur on the lips outside the mouth, not inside the mouth, then they can spread that herpes virus to your genitals. So we used to differentiate between type 1 herpes and type 2 herpes. But if your partner has herpes on their mouth, they can certainly give it to you on their genitals. And this is a really important thing about herpes. the virus can be shed whether or not you have an outbreak, which makes embarking on the whole sex thing kind of scary, but this is true. We do know this about herpes. Of course, it's much more virulent if you have a sore itself. So if your partner has a sore on their mouth, you definitely don't want them to be having sex with you with their mouth or kissing you, because the virus is very likely to be spread. The other thing that can be spread this way is HPV. Now, the research on this is pretty new, but it's looking like a lot of oral cancers, throat cancers, anal cancers. And we know for a long time now cervical cancer is being caused by the HPV virus. So I'm just going to use this as a pitch for everyone out there to get their HPV vaccine. It's now recommended for men and women. It's either partially or totally covered here at Student Health Services, depending on what other services you've received. So please come by and ask us about this, particularly if you haven't had that much sexual contact. It doesn't really matter what your age is. I tend to think of it more as a number of partners issue. So if you're new at the sex game especially, you definitely want to get that HPV vaccine. And then you don't at least have to worry about the most virulent forms of HPV. It's true you can still get the virus, but you won't get certain types, and it'll provide you with some protection. Other than that, I would say go for it and have a good time, as long as you're both consenting adults.
Great. Well, thank you so much, Lisa. And thank you for listening to this version of Sex Talk.
We'll be back again, hopefully in the next couple weeks, with answers to some more of your questions. Take care.